Think forward. Think Research Channel.
So I've been at Stanford for a long time. My initial interest was in biology and cancer research, and having spent 3 or 4 years in the laboratory, I became enamored with clinical care and tried to do both for a couple of years and realized that that was just not going to happen for me because I wanted a life outside of the hospital once in a while. And so I focused on clinical research, and I work in collaboration now with a lot of laboratory researchers. So somebody else holds a pipette and comes up with bright scientific ideas, and what I try to do is apply them to the patients I treat or come up with new ideas for a cancer treatment based on our collaborations with the laboratory. So I'm going to share with you just some of the advances with a little bit of a local flavor in colon cancer. And to do this, I have to ever so briefly review a little bit of the biology, so we're all starting with the same baseline here. Then we'll work a little bit through prevention and screening, because that's really where the major impact will be made on colon cancer. As much as I'd like to take credit for some of the research we've done in trying to help patients with colon cancer, really as a population we could do a lot better if we just prevented this damn disease. What I'm going to try to convince you of is that this is a preventable disease. So the biology. It's very important to appreciate that colon cancer arises from polyps. Polyps are little growths, much like a wart. They grow on the inner lining of the colon. Now, on the inner lining of the colon, you don't see a polyp. You can't see it with a typical CT scan. You can't see it. You can't detect it by a good abdominal exam. They're usually well beyond the reach of your finger. So when your physician examines the rectum with a finger, they're not going to see it. They're not going to see or feel a polyp in most circumstances. Polyps sometimes bleed, but most of the time they don't bleed. So bleeding is not necessarily a way of detecting polyps. When the polyp has abnormal cells in it, those abnormal cells can become cancerous. And when they become cancerous, they can overgrow the polyp, much as a bad seed would overgrow a plant and not only take over that plant, but then put roots into the rest of the colon and spread via the blood or the lymph nodes. So colon cancer is a cancer which always arises from polyps, which could be readily recognized by a colonoscopy. Cancers frequently bleed. Once a polyp has become a cancer, then it will sometimes bleed, and you can detect the blood in the stool. So that's one of our tests for detecting cancer. But it's not a great test for detecting polyps. From going to polyp to cancer, it requires multiple genetic steps. These genetic steps involve specific changes in the DNA, and what those changes evolve, if you can imagine that this is normal colon mucosa, this is a polyp that has arisen from that. So these are abnormal cells, but they're not yet cancerous. These cells are not yet able to invade other tissues. They're not yet able to spread to other places, and yet they're clearly abnormal, and we can detect those abnormalities by looking at these cells and looking at the DNA. Given some time, and that time might be 5 years, might be 10 years, but in some unfortunate individuals it might be 1 or 2 years, these abnormal cells can become cancer cells through the acquisition of specific genetic changes. And our understanding of those genetic changes is really evolving very rapidly. And suffice it to say that a number of genetic steps can lead to an adenomatous polyp, and a number of other genetic steps can lead to a frank cancer. So what are some of the clinical facts about colon cancer? Number one, it's a pretty common cancer. A lot of people don't appreciate this. Most people, when asked in the community, what are the common cancers? Well, breast comes to mind, lung comes to mind, maybe prostate comes to mind. But in fact, colon cancer is the second leading cause of cancer death in the United States. So it's a very common cancer, and it affects men and women equally. Some women I've heard say, well, I don't need a colonoscopy because women really don't get colon cancer. It's not true. Equal risk of developing colon cancer. And yet, it's among the most preventable of all cancers. I want you to think about this. How popular are mammograms? Mammograms are very popular. They're popular because about 15 years ago, the American Cancer Society and other groups advocated for screening for breast cancer. And now, at least in California, about 90% of women over 40 get a mammogram. What does a mammogram do? A mammogram allows us to diagnose a cancer at an early stage, which is more likely to be curable. So we can diagnose cancers at an early stage with mammography. For colon cancer, if you find a polyp with a colonoscopy and you remove that polyp, you actually prevent the cancer. So it's not just diagnosing at an early stage, you're actually preventing cancer by doing colonoscopies. In fact, the better analogy for screening for colon cancer is a pap smear. What is a pap smear? A pap smear is taking some cells off the cervix and looking at them under the microscope. And if those cells look like they're dysplastic, that means funny looking, they're atypical, they're pre-malignant, that cervix can be treated right then and there, or sometimes with a subsequent freezing procedure, or sometimes with a little bit of heat, or sometimes even with a surgery. But that cancer can be prevented. So in fact, a lot of people don't really appreciate this, but in 1940, which isn't that long ago, 1940, cervical cancer was the leading cause of cancer death in the United States. Now it's down around 9th. And the reason for that is because pap smears have essentially prevented cervical cancer among all those women who get their annual pap smears or biannual pap smears. So that's more like colon cancer. We can actually prevent colon cancer, and that's got to be the take-home message from today. That's not a very interesting message, but that's the important message. The other point is that the US population, as of about 3 years ago, was highly unaware of colon cancer, and furthermore, unaware that there were any preventive measures or treatments for colon cancer. And it's with people like Katie Couric, who have been so brave as to undergo a colonoscopy on national TV. It's for people like Dr. J, one of my heroes, famous basketball player who's willing to go out and talk about cancer, and a number of other celebrities in the American Cancer Society, and a number of colon cancer organizations now that are trying to bring the community up to speed on what colon cancer is all about, that it's a common problem, it's a serious problem, but we can prevent it. So part of this is just to make you aware of that. Now, what's the bad news? The bad news is that once it's diagnosed, if it wasn't prevented, once it's diagnosed, we don't cure everybody. People with stage 1 disease, stage means that we define the extent of the cancer. We define how big it is, where it rose from, whether it is spread to any lymph nodes, whether it's spread to any other organs. And we give it a stage. The stage allows us and academics to communicate with one another. So if I do a study on stage 3 colon cancer, I can talk with my colleagues at Harvard who did a study on stage 3 colon cancer. We can compare results. Okay? We stage it 1 through 4. You don't get to go from one to the other. You are the stage you are when you're diagnosed, and that is your stage. The cancer might come back, but you might be a stage 1 colon cancer if the cancer has not had a chance to go through the bowel wall. Remember, it always arises from a polyp on the inner lining of the bowel. If it has a chance to go through the bowel wall, then it's stage 2. If it has a chance to then involve local lymph nodes, remember lymph nodes are there to help drain fluids and help fight infections, but lymph nodes don't do much to fight cancer. They just serve as convenient freeways for cancer cells to travel. If it involves the lymph nodes, then it's stage 3. And if it has had the opportunity to spread to any other organs, like the liver or lung or bone, then it's stage 4. Okay? So we give a stage to every cancer we diagnose, 1, 2, 3, or 4, and that stage has important meaning in terms of prognosis. 5-year disease-free survival. That's an academic term. You want to see the word cure there. Okay? So the chance of cure is pretty close to 5-year disease-free survival for this cancer. For stage 1, we don't cure 100%, but we're pretty close, 90 to 95%. For people who have disease that has spread through the wall, we're 70 to 85%. For people who have lymph nodes that are positive, a bigger range, 35 to 65%, depending on how many lymph nodes, how big the tumor was, how ugly it was, but a bigger range. Stage 4, people who are unlucky enough to have had the disease spread to other organs, liver, lung, we cure precious few. Now, I think that this number is going to change dramatically in the next 5 years because we have so many better treatments for stage 4 disease right now. But right now, the historical number is less than 5%. This term here is a little bit of a controversial term, but one that we're using more and more. It's called metastatectomy. Well, a metastasis means other place in Latin. It means that the cancer has spread to another place. And the most common place for colon cancer to spread to is liver, which would make it stage 4. Those patients don't have a very high chance of cure. However, there are exceptions. And the exceptions are those patients who have stage 4 disease who can successfully undergo resection, surgical removal of their metastasis, the site where their cancer spread. Those patients perhaps have a higher chance, 5 to 15%, in some small series as high as 25 or 30% chance of 5-year disease-free survival. Okay? So this is a small subset, but it's becoming an increasingly important subset as we get better and better treatments that can make patients more likely to be resected. Pizza can fight cancer, Italian study determines. Okay? And I like the quote, authors acknowledge that pizza is among the foods that most closely associated with their country. And they cite evidence that the countrymen who eat pizza regularly once a week or more are less likely to develop cancers of the digestive tract. Well, that's good, but let's take this little test. Recognizing risk. Let's take this 55-year-old healthy woman who likes to run marathons for fun, and she's on a low-fat, high-fiber, maybe even vegetarian diet. She takes a baby aspirin a day because it's good for everything that ails you. Multivitamins because Reader's Digest said that was good too. And she gets an annual exam with her doctor who does a pap smear and says, your heart and lungs sound great, your cholesterol is fine, you're doing great. Okay? And then there's this guy who's sedentary, he's a little bit overweight, he likes Burger King. Okay? Beers and ball games daily. I can relate to that. That sounds good. But he had a colonoscopy last year. Who's more likely to get cancer in the next 5 years? Colon cancer. The woman, okay? The point I'm trying to make here is that this is a good thing. This probably lowers your risk of developing colon cancer. This is a good thing. This certainly lowers your risk of developing heart disease and maybe lowers your risk of developing colon cancer. This, in some studies, might lower your risk of developing colon cancer by 15, 20%. Multivitamins, who knows? And annual exams, not really very helpful. The only thing an annual exam is going to find is a big cancer, a cancer that's already spread. Well, having said that, this is what I would estimate would be the risk reduction with these various approaches. If you remove the polyp, you have a 90% decreased risk of developing colon cancer. Why only 90%? Because some polyps are hard to see. And so you just might miss them over a period of time. If you take calcium, there are some studies that suggest you have a decreased risk by about 25%. If you take aspirin-like drugs, this is a very interesting study. This arose from an observation that people with rheumatologic disorders, arthritis, had a lower risk of colon cancer. Well, why? Was it because their arthritis was somehow an inhospitable environment for colon cancer? There's something about their immune system that triggered both the arthritis and prevented colon cancer? No. It was that they were taking a lot of non-steroidal anti-inflammatory agents, a lot of Motrin, a lot of Sulindac, a lot of ibuprofen of all types. Okay? Aspirin. And in fact, so people looked at that and they found that true enough, aspirin, Motrin, and a variety of drugs actually decrease the risk of polyp formation. So this is a real thing. But if you take all the effects together, you're at best a 25% decreased risk. Exercise, who knows? Folates, a lot of theory. Low-fat, high-fiber, good epidemiologic evidence. Meaning if you look at a population of 10,000 people who have this kind of diet and 10,000 people who eat Burger Kings, the Burger King group gets more colon cancer, more adenomas. However, if you take a group of people, and then you put half of them on a low-fat, high-fiber diet, the other half you just let them do what they want, you're not able to see any difference. And so this is still a big question as to whether we can actually change somebody's diet and change their risk. Even estrogen replacement. For all the bad things estrogen replacement does, maybe it decreases the risk of colon cancer a little bit. Smoking, another smoking-related cancer. Okay? Not just lung cancer, but colon cancer too. That just was discovered just a couple years ago. But colonoscopy can actually remarkably decrease your risk. So that slide just tells you, number one, the epidemiology doesn't always jive with a prospective randomized trial, which is kind of the gold standard for scientific examination. By prospective randomized trial, what I mean is we're going to head and ask a question of, does this thing work? And so we're going to put 5,000 people on calcium, and the other 5,000 people will do whatever they want. We can't exactly tell them not to take calcium. That would be unethical. But we're going to put 5,000 people on calcium, and then after 10 years, we're going to find out how many of the 5,000 in each group got colon cancer. That's a prospective randomized trial. That doesn't always confirm what epidemiology tells us. Now, epidemiology is a science in which you're looking at populations of people, and you're trying to draw conclusions based on behaviors, lifestyles, environmental exposures, and a disease, right? That's what epidemiology is all about. Well, as an epidemiologist once told me, if you were to take cross-sectional epidemiology too seriously, you would conclude, without a shadow of a doubt, statistically sound conclusion, that in Florida, you were born Cuban and died Jewish. Right? More people born Cuban die Jewish in Florida. So you have to be careful with epidemiologic conclusions. Now, the cost effectiveness is still an important debate and relates to the sigmoidoscopy, colonoscopy, and other tests that we'll talk about. What is the most cost effective? It's easy enough to say that colonoscopy is the gold standard. Can we as a country afford colonoscopy in everybody? Maybe, maybe not. Right now it depends on your insurance, and some insurance plans don't approve colonoscopy as a screening technique. So Kaiser, for instance, uses sigmoidoscopy. Now sigmoidoscopy is pretty good, and Kaiser is good enough to get most of their patients have screening. And I firmly believe that the best test is the one that gets done. That I'd rather have a sigmoidoscopy than nothing, and I'd rather have a fecal occult blood test, just checking for blood so you can detect a cancer early, if you're not going to get a colonoscopy or a sigmoidoscopy. But the important point here is that a healthy lifestyle is no substitute for removing the polyps. And I can tell you, because I have a number of marathon runners, very healthy young people who have colon cancer, and they're asking me why. I said, well, it's just bad luck, bad genes. Okay, so what are the screening options? Colonoscopy is still the gold standard. Sigmoidoscopy is a very good treatment that can detect probably 70% of colon cancers, but it is going to miss some. In fact, as I mentioned, colonoscopy misses some. Colonoscopy misses about 10% of polyps, small polyps. Fecal occult blood test is only looking for blood, so you're not going to find the polyp, the precancerous lesion. So this is not really a way of preventing colon cancer. This is a way of detecting it early, which is good. If we can detect them all in stage 1, we can cure 90–95% of patients. Okay? So detecting early is good, but it's not as good as preventing the disease. This used to be one of the standard tests. It's really on the way out. You know, there are certain parts of the country that don't have access to these, and they'll do a barium enema. That's just putting dye up the bottom and then taking pictures. It's not a great test. It's too insensitive. On the horizon, there's been a lot of press recently about virtual colonoscopy, unfortunately in part because it became a fashion of sorts. A fashion in that there were private groups that are willing to do it and charge you lots of money for it. And then those private groups competed with one another. And I was just absolutely dumbfounded. I almost drove off the road when I was coming into work one day and on the radio they advertised, come in, get a whole abdominal CT scan to make sure you're healthy, and we'll throw in a virtual colonoscopy, and if you come in the next 2 months, we'll throw in a head CT for your wife or your spouse. And so, that tells a lot about what you think about your spouse, but they're throwing in all these head CTs. That, number one, the quality of those is terrible. Number two, I think it's just outrageous that they can advertise that, because it had not been demonstrated to actually detect cancer early. We are, now having said that, Stanford is part of the leaders in developing new techniques of virtual colonoscopy. So it's really something that will be here soon. But it's not ready for prime time, and to charge people tons of money. And then I've had 5 patients in the last 2 years who came to me with advanced colon cancer, all of whom had virtual colonoscopies about a year or 2 earlier, and were so relieved that they then ignored the fact that they were bleeding. Because they had a virtual colonoscopy, they said they got a clean bill of health. So virtual colonoscopies are overrated in the community, but they still have legitimate potential. I'll show you some of that. Now, I want to just spend a second on this, because I think this is in the future. I think that the stool DNA tests are going to be a very valuable test in the future. Now remember, we test stool for blood. You're all familiar with the fecal occult blood test. That's where you get a little sample of stool, you put it on a little card, then the doctor or nurse puts a little developer on it, and if it turns black, they say, aha, there's some evidence that you might have some blood in your stool, and that's reason enough to get checked up and get a colonoscopy, or to find out where the bleeding's coming from. That's not very sensitive, meaning it doesn't detect polyps at all, and many cancers only bleed intermittently. So if you check that once a year, you might miss the cancer. But let me tell you, if you check that once a year, just the blood tests, just the fecal occult blood tests, a very large study, 50,000 people in Minnesota did that study with fecal occult blood tests once a year, compared with 50,000 people who didn't, and there was a 30% reduction in colon cancer mortality over a 10-year time frame. 30% reduction in colon cancer mortality just by looking for the fecal occult blood test. Think of what it would have been if we had done a colonoscopy. Okay? So it really does add value, but imagine what we could do if we could detect polyps. And it turns out that we can. Right now it's very arduous because now we've identified some of the genetic changes that go from normal tissue to polyps to cancer. We can detect genes. And believe it or not, genes are shed in tiny numbers all the time. Tiny cells are shed, not blood, but tiny cells are just shed both from the normal gut and from the polyps. And by taking a stool sample and using something called polymerase chain reaction assay, something that won a Nobel Prize by a surfer in San Diego, believe it or not, this PCR test can amplify that tiny bit of DNA into something that we can measure and read and determine exactly where it came from. And if we find a gene associated with that polyp, we can go in there and find that polyp. So this is a picture. It's a pretty nice picture. This is a real colonoscopy on the left. Same patient. The virtual colonoscopy on the right. You can see a tiny, about a ½ centimeter polyp. And so this is done basically on a CT scanner. It has to be a certain kind of CT scanner, which actually, for a number of years, was not present in the community CT scanners. It's usually CT scanners we slice like this, and we look at those pictures and planar images just through the body like that. Well, for these reconstructed images, they put them back in 3 dimensions for us, and they do that with a computer. It's a complicated procedure. And it still requires what most people consider to be the worst part of a colonoscopy. It's the bowel prep. You have to have a clean bowel for this to be worthwhile. And the bowel prep is miserable. Stanford's actually working on trying to come up with bowel contrast agents for MRI, so you don't have to have a bowel prep. You just swallow some dye, it labels the stool, and then you can eliminate the stool as a labeled substance from the computer. So you end up having a vacuum inside the colon. Data acquisition, how fast the computers take up this information, how much information. It in part depends on how much radiation you give. right? Because this is a CT scanner that's imaging through radiation. The image processing is incredibly important, and that's one of the things that some of the folks here at Stanford are world's experts in. And then diagnostic interpretation, of course, is the key. Here's a little polyp in a routine slice of a CT scan. You can see air in the colon and then this little nubbin there. Here's a close-up of that little nubbin. Now, you would never see that on a routine CT scan. They're just showing this backwards. And there it is on the virtual colonoscopy on the left, not all that in focus. And here it is when they went in to find it with a colonoscope. So that represents a successful find of a polyp. Okay, so now what the computer does is it takes these air images and it reconstructs them in 3 dimensions, and then you can pull them out of the computer, and then you have this kind of free-flowing colon highway. And then you can take that colon highway and splay it open. And so a lot of the original images with the virtual colonoscopy was radiologists looking down as if you had this long tube and you just cut it and you opened it. And now you're looking down looking for a polyp. Well, you can see how complicated it is. There's a lot of folds, a lot of normal folds. And so it's not that easy. And in fact, when we first started doing this, it would take hours and hours. And you can bet that the people in the community who charged $300 weren't spending hours and hours looking for these things, right? So it can take hours and hours looking for polyps. And here's one such look. So you splay it open, you find this tiny abnormality, you go in, and there it is. Although this is an autopsy photo, and the radiologists were quick to point out that it's a different subject, but this is the kind of picture that you look at. Now, Stanford has been excelled in a lot of the information technology areas that I am frankly quite lame in. But what they do here is they now have a CAD program for the computer to identify polyps or abnormalities in surface curvature that then alert the radiologist to go look at that area. So in fact, by doing a number of surface curvature calculations throughout the entirety of the colon on a computer, and by making certain rules by which you will determine which type of curvature you're going to analyze, you can end up making little hotspots on the program, and then you can direct the eyes of the radiologist to those hotspots. That will greatly increase the time, decrease the time and increase the efficiency of analyzing these very expensive data collections in order to try to find a polyp. So screening which test is best, the one that gets done. I already mentioned that just fecal occult blood test has a dramatic effect. So if that was a minimum standard, we'd do better in this country than what we're doing right now. So I'm going to talk a little bit about diagnostics, but not go into much detail with them. For diagnostics, what we're talking about is once a colon cancer has been diagnosed, what sorts of imaging tests or what sorts of tests can we use to better understand that cancer, to stage that cancer? We have, for a while, we had the only PET CT scan in Northern California. Now we have 2 of them. What a PET scan is a way of imaging functional tumors. That's not a very good term. But sometimes the PET scanner is called functional imaging. So PET isn't, the dog and cat sort of thing that it brings to mind. It's positron emission tomography. So that's why we call it PET. And positron emission tomography, when you inject a radiolabeled glucose, will be preferentially taken up in areas of inflammation or tumor. And so it's a way of localizing tumor to the radiologist. And what we've been able to do is join that with a CT scan, so we can not only see the differences in density and the exact anatomic location that CT scan gives us, but now we can determine exactly what portions of those abnormalities represent cancer. Now, this is a very helpful test for a lot of us who will look at a lymph node and wonder, well, is that cancer or not? And exactly where is that? Is that a place that a surgeon can get to? Is that a place I should aim my radiation beam at? In fact, we have one of these in our radiation therapy suite downstairs here now, so that in the coming months, when a radiation oncologist is trying to design the treatment field for a cancer, he can look at not only a high-resolution CT scan, but look at a PET scan which might show that the tumors actually extend a little bit further than what the CT scan might recommend, and he can extend the treatment field to include that. So another very valuable technology that's brand new. We talked a little bit about virtual colonoscopy, and we have other high-resolution CT scans that are just absolutely amazing. I mean, these scans now look better than the cadavers in terms of accurate anatomy that we all learned on in medical school. Now, we talked about diagnostics just briefly. Prognostics means what tests will tell us what the chances of the cancer coming back are. And how sophisticated can we be in differentiating people who have a higher or lower risk of recurrence of their cancer? That's very important. Stage 3, for instance, if I said that somebody had stage 3 cancer, had a 50% chance of their cancer coming back, statistically that's all I know, because thousands of patients were treated with stage 3 cancer and 50% had their cancer come back. Well, wouldn't you like to know if you were the one who had the cancer destined to come back? Or wouldn't you like to know if you were the one who didn't have a risk of the cancer coming back? If you knew that your cancer risk was very low, even though you're stage 3, you might say, well, then don't give me any radiation therapy. Don't give me any chemotherapy. I'm among the cured from surgery alone. Just as importantly, if you knew that you were at higher risk than your stage suggested, you might say, well, I'll go for that extra treatment. So it's a very important decision. And our standard ways of prognostication are really quite primitive. Stage, which I described to you, 1 through 4. Whether the tumor looks like it's invaded vessels on the microscope, the number of lymph nodes that are taken, and the number of lymph nodes that are involved. What the cells look like under the microscope, that's called histology. How well behaved the cells look under the microscope, that's called differentiation. And then a CEA, which is a simple blood test, sometimes helps sort out the really bad players from the average players. So these different standard prognostics are frightfully old. And what we really want to do is move to the right here, to molecular prognostication. And we already have some. At Stanford, everyone with colon cancer now, as of 3 months ago, gets a molecular test called microsatellite instability. I won't have time to go over that with you at all, but that's one test that is helpful in not only determining what their overall prognosis is, because people who have microsatellite instability actually do a little bit better than people who don't. But I think just as importantly is it helps us determine whether that cancer is likely to be an inherited cancer. Now, I treat a lot of people with cancer, many people with advanced cancer. I would say that I've prevented more cancers than I've cured. And the reason for that is because with tests like this or with asking about family histories, I can get siblings, kids, parents to have their colonoscopy done and prevent a cancer that otherwise might have occurred, particularly if they had an inherited gene. And microsatellite instability is one clue that an inherited gene might be involved in that person's cancer. There are other tests. I won't go into any details, except I just want to talk about gene arrays. Again, it's a little bit self-serving. Genomic profiling was actually developed here at Stanford by a very bright guy named David Botstein, who revolutionized molecular biology and made it applicable to clinical questions. Basically, what he did was develop the gene chip. Very nice, apropos term given the Silicon Valley location here. But what the gene chip does is a little microscope slide, this big. In fact, I have one in my pocket over there. The size of a microscope slide, etched. You can etch 40,000 wells, microscopic wells in that microscope slide. And into each well, you can put a little bit of DNA, RNA from the tumor or RNA from normal tissue. Normal tissue is on the left because it looks nice and round and organized. Tumor tissues on the right, on the top. Isolate the mRNA, make DNA out of that, put the DNA into each well, and then you can do different tests to see whether the genes in each well were underexpressed or overexpressed. Now this is a little bit complicated, but just let me tell you that the genes that make your thumbnail are the cells in the thumbnail have the same genes as the cells in the brain, which have the same genes as the cells in the heart, which have the same genes as the cells in a white cell, which have the same genes as a cell in the liver. Why do they look so different? They look so different because the cells learn to turn on some genes and turn off other genes. So we've all got the same set of chromosomes in all the cells, and our cells learn by being in a special tissue to make some genes work and turn off other genes. And in fact, that's all cancer is about. Cancer is all about having the wrong genes turned on or the wrong genes turned off. When the wrong genes are turned on, we call them oncogenes. Oncogenes mean that gene makes the cancer grow. When the wrong gene is turned off, we call that a tumor suppressor gene. We all have tumor suppressor genes. Our tumor suppressor genes are suppressing tumors all the time. If that gene gets knocked out, gets mutated, and is no longer effective, that cell has a chance of becoming a cancer. So this is very relevant not only to normal tissue development, but also to cancer development. And we can now look at 40,000 genes at one time on a microscope slide at tumor tissue and normal tissue. We can also ask other questions. 40,000 genes one time, patterns of expression. We can take 100 patients and take 100 patients whose disease metastasized, 100 patients who didn't, and look at their gene patterns. So it's an incredibly valuable science for developing prognostication, and although not ready for prime time, but eventually available for prognostication, as well as telling us exactly what treatment should we use for a person. Is this tumor going to respond to 5-FU, or does this tumor need something like oxaliplatin? Is this tumor not going to respond to anything and really needs experimental treatments? We will be able to answer those questions, as well as the important questions of will I live or will I die? What I'm going to show you now is an even more elegant example that's being developed right now for colon cancer. And I won't even try to describe it to you, except that it's a way of looking at specific colon cancer-related genes with 5,000 probes, all in the same test tube. An incredibly cheap maneuver. So we'll be able to look at a number of important chromosomes. 18q just happens to be an important chromosome for colon cancer. We'll be able to look at that in some exquisite detail with 5,000 probes in one test tube on one patient. And I think that this is something that will almost certainly become a company. I don't know which company, but we're using it right now as a feasibility trial to see how much information we can get from this. Okay, so now let's go on to treatment. Stanford is known for its lymphomas, its lymphoma research. In fact, Stanford is one of the world's centers of expertise in lymphomas. And having grown up here in lymphomas, I fought an uphill battle to study something like colon cancer. Because frankly, we cure most lymphomas. And we don't cure most advanced colon cancer patients, unfortunately. And we have many treatments for lymphomas. We have many drugs. And for 50 years, we only had one drug for colon cancer, 5-FU. That was the only drug we had for 45 years. I would venture to guess that in the past 5 years, with all of the advances we've had in all the cancers, in the past 5 years, we have made far more advances in our understanding and treatment and outcomes of colon cancer than for any other cancer, with 2 exceptions. One exception you may have read about, it's Gleevec for a rare leukemia called CML. Gleevec is a triple, if not a home run, for that disease. You don't hear about home runs in cancer very much. That's a triple or home run for CML. And it's a double, Gleevec is a double for another disease called GI stromal tumors. You don't hit many doubles. We hope for a single every time we get up to bat. So in fact, with 5-FU as our only drug, which came into being in 1952, and it was deemed to be a cure for cancer at the time. It was a rationally designed drug. It was supposed to be incorporated in RNA and DNA and was going to kill growing cells, and therefore it was going to be God's gift to cancer treatment. 5-FU is all we had. It wasn't for lack of trying. We have tried lots of drugs, 3,000 patients treated with lots of other different types of drugs with an overall response rate, chance of shrinking a cancer of about 2%. That tells you how tough a disease this can be. 2% chance of getting shrinkage with all of these drugs in 3,000 patients on studies. So it was pretty dismal. It was not for lack of trying that we weren't making advances, just that none of the drugs that were working great for breast cancer, ovarian cancer, lymphomas were not working for colon cancer, and all we had was 5-FU. So that was history. Now we've entered the era of targeted therapy, and this is a new era. So I'm going to tell you a little bit about targeted therapy. It's kind of an exciting biology for those of us who are used to giving chemotherapy. Now, chemotherapy is still good, and targeted therapy won't stand alone, but targeted therapy is a new concept that I hope will fly not only for colon cancer, but for many other cancers, and I'm convinced it will. Just as an example, targeted therapy is you have to identify a target. You have to know what you want to hit. You ideally want to hit something on the tumor cell that's important to the growth of that tumor cell so that if you hit it and knock it out, the cell can't grow. Once you identify the target, you have to develop a drug or an antibody or something that will bind to that target. So thank God for entrepreneurism. As much money as the pharmaceutical industry is making right now and as much grief as they take, they're giving us good drugs and lots of them. A lot of competition, a lot of money involved, but it's actually working. Some examples, Rituxan. Rituxan was the first antibody, which is a drug, that was used to treat cancer. It was an antibody that was targeted a protein called CD20, which sits on the surface of B-cell lymphomas. The most common type of lymphoma is B-cell lymphoma. It's an antibody that was developed here at Stanford by Ron Levy, who I think is talking 2 weeks from now. He treated the first patient with lymphoma, a patient who had had chemotherapy, and the chemotherapy had no longer worked. He gave him lymphoma in our old clinic in the basement, which some of you may remember with some dread. And that patient still comes to his grand rounds lectures 23 years later. So the first patient treated with a monoclonal antibody was treated here at Stanford, and that patient was an astounding success, still in remission 23 years after having grown through his chemotherapy. So Rituxan has a lot of home knowledge. It's an antibody for lymphomas. Now it's used all over the world for almost every B-cell lymphoma. Herceptin was the second antibody that was approved, and that binds to a protein that's on the surface of many breast cancer cells, a protein called HER2/neu. What I'm going to tell you about is the other antibodies, the other, C225 and Avastin, I'm going to focus on a little bit. Now, what is targeted therapy? So targeted therapy, as I said, implies that you have a target to aim at. And then you develop a drug or a strategy to inhibit that target. So what's a valid target? Well, there was this guy named Judah Folkman who I invited out to Stanford when I was a graduate student, which was a long time ago. I don't remember when that was, but I invited him out here, and he gave a talk, and I frankly thought that he was a little bit loony. He's a surgeon, which makes him a little bit loony. But he was very energetic, really believed in what he did, and just took things a step further than we were kind of willing to accept. Well, God bless him. He took him, and he persevered, and he stayed with it, and he really made this a true field, angiogenesis inhibition. Angiogenesis means blood vessel formation. And so a tumor cannot grow unless it gets blood. Normal tissue cannot grow unless it gets blood. You need a blood supply to get oxygen and nutrients. How does a tumor get blood supply? Well, it's a simple thought. How does it get blood supply? Tumors aren't born with blood vessels feeding them. Tumors recruit blood vessels to feed them. The way they do that is they release substances. This is very insidious. Sounds like the evil empire, but they can actually release growth factors. One of the growth factors they can release is called vasculoendothelial growth factor. All that means is blood vessel cell growth factor. What does that growth factor do? It's released by the tumor. It goes and binds to what else but vasculoendothelial growth factor receptors. So we would call it VEGF, vasculoendothelial growth factor. VEGF binds to VEGF receptors. What does that receptor do? It sends signals to the nucleus and says, I've got to grow. Even though maybe I shouldn't grow, I've got to grow. And that normal cell, when stimulated by a growth factor, says, that's my job. When I'm stimulated by the growth factor, I grow. So that's what he does. He grows and forms vascular supply to feed the tumor. Okay? So what can we do about that? Well, you can isolate the vasculoendothelial growth factor, and you can study what it does, and you can study what it binds to, this vascular endothelial growth factor receptor, so tongue twister. And then you can study what happens when the receptor binds to the growth factor. Well, it sets off a bunch of signals, chemical signals, that then lead to the nucleus that tell genes to turn on. Those genes that turn on tell the cell to grow. Okay? Very simple mechanism. Now, it's of course much more complex than that, but it's a very simple concept. So how can you block this mechanism? Well, if you take VEGF, the growth factor, and make an antibody against it, you just suck it up and get rid of it. So it's no longer available for binding. So you can take an antibody, hit the VEGF. Or you can take an antibody and bind to the surface of this receptor so that the growth factors can no longer bind there. Okay? So now you're going to block any binding. Or you can take a small molecule, not an antibody, and I won't go into the details of what those are, but a small molecule that will go in and bind to the signaling system. So once this is bound, remember, it sends signals through a series of molecular reactions that go to the nucleus. Well, let's just knock it off right here. Believe it or not, there are 55 clinical drugs right now, 55 clinical experimental drugs right now testing various aspects of this. All of these are being tested right now in clinical trials. And Genentech picked the left one. And Genentech made a drug called Avastin. And last May, they presented their results to 30,000 oncologists. And they showed that chemotherapy, a chemotherapy regimen called IFL, plus placebo versus chemotherapy, IFL plus Avastin, which the generic term is bevacizumab. So bevacizumab or Avastin had a higher chance of shrinking colon cancers, 35 to 45%, had a longer time before the colon cancer grew, and people who got the Avastin lived, on average, a longer time. Now, this may not be very impressive, 5 months, 4.5, 5 months. And it doesn't sound very impressive. That's a median survival. Some people are out years longer than they would have been. Some people only a few months. The important thing is that this and one other trial are the most positive trials of colon cancer ever. Remember, 5-FU was all we had for 50 years, and these drugs are making significant incremental gains. Okay? And what's remarkable is without any additional significant side effects. You don't lose your hair with Avastin. You don't get sick to your stomach with Avastin. You don't get lower blood counts with Avastin. There are some side effects, but the usual chemotherapy side effects don't happen. So that's inhibiting blood vessel formation and applying it directly to colon cancer successfully, so successfully that it was approved last month by the FDA. And now patients right next door here are getting Avastin with their chemotherapy. Now I'm going to talk another signaling mechanism. This time, instead of inhibiting the blood vessels' growth, let's talk about the tumor cells' growth. So a target was identified on tumor cells called EGFR. EGFR stands for epidermal growth factor receptor. It's got a curious history. It's called epidermal growth factor receptor because it was first identified on skin cells. People in a laboratory in Houston studying skin growth in culture were trying to get skin cells to grow. They found out that if you gave cow serum, only because you couldn't get human serum, fetal serum, they could get cells to grow. They found out, they isolated the growth factor and they called it epidermal growth factor because it would stimulate these skin cells to grow. Once they identified epidermal growth factor, they then identified the epidermal growth factor receptor and found that the receptor, through a signaling cascade, went to the nucleus and told that cell to grow. It's the same analogous mechanism to the vascular endothelial growth factor blood vessels. In fact, it's the same thing that makes a fetus become us. The same signaling mechanisms tumors use to their advantage. The same signaling mechanisms that all of our normal body cells have. So what the epidermal growth factor receptor is a potential target. And in fact, epidermal growth factor receptor is found on 75 or 80% of all colon cancers. Now, when it's bound by any putative ligand, that red dot, it sends a signaling cascade to the nucleus. And instead of just growth, this signaling cascade can lead to resistance to drugs, increased survival, metastasis. So lots of bad things. So it's a target. So companies developed ways of inhibiting the target. Two general ways were used. One is by using monoclonal antibodies, which are usually big molecules that you can make bind to anything as long as it's on the cell surface, because big molecules don't get into the cell. So the monoclonal antibodies bind to the outside domain of this epidermal growth factor receptor and inhibit the binding or in some way impair the action of this growth factor receptor. The other strategy is to develop small molecules that come in here and inhibit this signaling enzyme. These are known as tyrosine kinase inhibitors for the people who are interested. And a number of small molecules are in development. Now, the leaders in this, not because they're the best, but because they were the first to come along and therefore the most advanced in clinical trials, are C225 and ERISA. Okay? So just remember that C225 is the leading antibody because it was first to come along. ERISA was the first small molecule to come along. C225 was developed by ImClone. We were so excited about some of these results where a group in New York looked at patients who had colon cancer who had already had CPT-11, a common chemotherapy drug. They had CPT-11 and CPT-11 wasn't working. Well, what do? They did something crazy. I thought it was crazy. They gave CPT-11 plus this antibody. I would never have done that to any of my patients. That would just seem like this is so counterintuitive. Why would you give the same drug that wasn't working and then just add this antibody? They did that, and they saw that 23% of the patients had a response. Well, that was remarkable. And I tell you that's remarkable because this drug alone, if given to patients who already didn't respond, has a 0% response rate. I mean, if it's not working, it's not working. What's more is if you give this drug to people who never saw it before, you only have a 15% response rate. And here you get a combination, you get a 22%. To this day, we have no idea why. But that's one of the most exciting areas of research right now, is trying to figure out why to see if we can apply this to other treatments. When they gave the drug by itself, the C225 by itself, a 10% response rate. Remember, 10% doesn't sound very good. It's not very good. We need to do better. But 10% for a drug that causes acne is a lot better than 15% for a drug that causes hair loss, diarrhea, nausea, vomiting, blood count suppression, and sometimes kills 1 or 2% of patients. Okay? So these are remarkably safe drugs that are getting small but significant benefits in patients. And once we can identify why these patients are benefiting and others aren't, we hope to tweak the system and boost these numbers. And now we're giving it right across the hall here. Actually, before that drug got approved, we took the different stance. We thought, well, wouldn't it be nice to use a pill? The advantage of the small molecules is they're available as pills. They inhibit the same protein, but just on the other side of the cell. So we use a drug called ERISA, a small molecule that inhibits the tyrosine kinase domain of the epidermal growth factor receptor. And we did a study, and we're still doing a study, on patients who had no prior chemotherapy for their metastatic disease, so advanced disease patients for whom there are no cures. And I'll have to preface this for you. The 5-FU itself gives about a 15% response rate. 15% of patients have significant shrinkage of their disease. With 5-FU in combination with chemotherapy, we're about 45% response rate, which is just in the past 5 years. We went from 15 to 45 in the past 5 years. Now we're seeing close to 80%. That's astounding. Breast cancer routinely sees 50 to 80% response rates for their drugs. This is the first time ever that we've seen an 80% response rate for colon cancer. And I have it on good authority that Erbitux, which again inhibits the same protein, in a study from Europe that they're going to present in May, has similar benefit in combination with the same chemotherapy. And what about people who had prior chemotherapy, people who are already resistant to chemotherapy? Those people in general have about a 10% chance of having shrinkage of their disease because they're already resistant to chemotherapy. In our hands, we're right now about 33%. Now, these are still small numbers, so I don't want you to take those home to the bank nor invest in anyone because of these. But I think that they're enticing. We've grown to expect responses, which is something we never did. We were always delighted when we saw responses. We always hope and pray for responses, but now we actually expect them. We're surprised when it doesn't happen. And here's an example. Here's a young gal who I'll never forget, and who's still doing okay, by the way. She was discovered to have colon cancer because she had been pregnant, had a little bit of hemorrhoidal bleeding that was felt to be hemorrhoids from pregnancy, and when she went ahead and had her baby, the bleeding didn't stop, and about 2 months later she had some abdominal pain, went to the emergency room, and she had a complete obstruction, so they did a surgery and they found cancer throughout her abdomen in her liver, so they closed her up and said, "I'm sorry." And so her family got the physician to call Stanford, and she came here the following week. And she was the first patient in our study. And when we saw her, she had a lot of disease. These dark spots in the liver are cancer. Both of these are pre-treatment. These are the same pictures after just 4 treatments, after 2 cycles of treatment. And I don't show, because we get shrinkage a lot, so it's unfair to just kind of brag about shrinkage. But the remarkable thing about this is that these spots not only got smaller, but after she had tremendous shrinkage of her disease. Now, the reason I show this is because we subsequently went in to remove these liver spots. There wasn't any cancer left in them. So this kind of response, unfortunately, doesn't happen as often as we'd like, but it happens just often enough that now we are looking at much more aggressive care for people with metastatic disease than we had ever imagined before. Okay, progress in metastatic colon cancer. So taking you back 1980, when I started at Stanford, the most common practice was not to even treat people with metastatic colon cancer. I would get many referrals from the community because patients wanted treatment and their doctors wouldn't treat them. They'd come here and I said, well, sure, we could give you this or that. But the standard in the community was not to treat colon cancer because there was no treatment that was effective. And treatment was toxic. As you go forward here, this is where we were 5 years ago. 45% chance of shrinkage, and really only about a 2 or 3 month improvement over no treatment at all. These are all patients with metastatic disease, incurable disease, looking at chance of shrinkage of tumor and what the median survival was. Recently, adding Avastin to a regimen, we got a 45% response rate, 20 months. What's curious is that this regimen here was better than the IFL that I showed you before by 4 months and by 10%. And what we're all anxious to find out, and what we'll probably find out by this summer, is what will Avastin and this regimen do, which is better still. So the question marks here are combining Avastin, combining oxaliplatin, which we didn't really talk about in any detail, another chemotherapy drug, which is a good drug, and combining these new EGFR inhibitors all together. Will we continue to get the incremental advances in outcome that we see with each drug by itself? And we have hints that we are. Okay? Hints. Not certainty yet, still experimental. Rectal cancer. So this is a little bit of diversion. Now, a lot of people get confused. Rectal cancer is colon cancer. It's just further south, right? But rectal cancer we treat very differently. The reason we treat it differently is because we can. What does that mean? We can give radiation down here fairly safely. 5,000 rads, 5,000 units of radiation we can give to here. We can only give 3,000 or 3,500 rads safely up here. So if you have a colon cancer, which is generally above the pelvis, and if you need 5,000 rads to kill a cancer, you really can't do that very safely. But down in the rectum, you can do that. Okay? So because we can, we do. This question here is, should we? And I say should we because sometimes that treatment hurts. So one of the other advances at Stanford and elsewhere is developing better radiation delivery. We have fancy new techniques to focus radiation in such a way that we've never had before. And so we can be more precise with the delivery. And I'll just try to show you a couple pretty pictures. This is a standard radiation field for an anus cancer, right at the bottom, okay? Standard radiation, you basically take a beam. So these are the hips, these are the pelvic bones, and the tumor is going to be right there. And you basically take a beam and you aim it from the front, and then you aim it from the back, and then you might come in from either side, and you hope that all the beams focus in the treatment volume, in the tumor volume. So the way you get the dose where you want it is that you have an overlap of the beams. The way you avoid the normal tissue damage is by having more beams, so that any one direction only gets a quarter of the dose through the normal tissues, but the whole dose is delivered to the tumor. That's not very fancy, but that's what standard radiation therapy had been since its inception. Do you know where radiation oncology was most famous? Right here. Henry Kaplan, one of my mentors, invented the linear accelerator for Stanford Medical Center. This is the newest of the radiation toys. It's called the CyberKnife. They've mounted a linear accelerator on a robotic arm that now can come in at virtually any angle in 360 degrees to aim at the tumor. This is the main limitation here was the software development, which was developed also here. And now with the CyberKnife, we can deliver exquisite doses all at one sitting to a tumor, sparing a lot of normal tissue. And we can deliver 90% of the dose to a volume that's only a centimeter or so away from the tumor, whereas that was never available in the old days. This is our current rectal cancer study, not to go through with any detail, but to let you know how we do things as groups. We see people, newly diagnosed patients in tumor boards, because for rectal cancer specifically, the radiation therapist might be very important, the surgeon might be very important, usually not as important as they think they are, but might be very important, and the medical oncologist adds value too. And we see patients together, and we review the x-rays together with a radiologist who's an expert on imaging rectal cancers. We review them with a gastroenterologist, oftentimes the same one who's done the endoscopy, who can tell us certain features of that person that might be important, or certain features of that tumor. We do it with a pathologist who can do special studies for us on the tissue sample. And we develop protocols together. We sit down every week and see patients with rectal cancer and pancreas cancer and gastric cancer and develop protocols together as to what should we be doing in the next 3 years. So this is a clinical study in which we're going to look at these new treatments, a pill form of 5-FU, so you don't need to have an IV infusion anymore. This new drug oxaliplatin, which just got approved a year ago, September. C225, which I just told you was Erbitux. It's the EGFR inhibitor that got Martha Stewart in trouble. Radiation. We're going to do a specialized PET scan, not a standard PET scan, but a PET scan that we think will tell us whether tumor cells are dying or not quicker than we would with a normal PET scan. We do PET scans before and after, get biopsies before and 8 days into treatment so that we can send the tissue to the genius that I work with who is doing all these fancy molecular assays to look for 5,000 changes in genes, in relevant genes. And then we send all patients to surgery, hopefully to have a curative resection, and then we analyze all the data and try to draw conclusions based on, does PET help us determine who's a good group? Do molecular assays help us determine who's most likely to respond? Might we someday be able to tell, based on a biopsy here at day 8, that we're giving that person the wrong treatment because they're not having the right molecular changes? We better shift to a different treatment. Those are all questions that we're trying to address. So how do we recruit the immune system? Basically, it's not by eating broccoli. I mean, you see so many things, people come in and say, yeah, all I need is this vitamin, and I recruit natural killer cells to my tumors. Fine, go ahead, just don't spend a lot of money on it. But there are ways that we can tweak the immune system, perhaps, to our advantage. The normal immune system doesn't help much, but maybe we can make it help. I'm going to tell you a little story right here. So someone I work with named Wenru Song is a fellow here. It's nice to train to be in an institution where the fellows are a lot smarter than some of the attendings, so I learn a lot from our fellows. He works in Ron Levy's lab, and Ron Levy's interested in immunotherapy for lymphomas. Well, Wenru says, well, why don't I try it with colon cancer? So he's taken some mice. That's a mouse, by the way. And one way we do these trials is you put a tumor in the side of the mouse. So he's got a tumor growing here. And then you can inject some chemotherapy into the tail vein, chemo, and you can see if the tumor grows or shrinks. And tumors will shrink, but they don't fall off. They shrink, and then they grow back, and then the animal dies. That's chemotherapy. Well, then you say, well, maybe if I took some cells from the immune system and injected them directly into the tumor, and these cells are called dendritic cells. These cells are kind of the professors of the immune system. The dendritic cells are the cells that educate the T cells as to what to attack. So dendritic cells go around picking up foreign material, like viruses or bacteria, proteins, and they process them, they put them back on the cell surface of the dendritic cell, and T cells just love to huddle around dendritic cells, like a classroom. And in that huddling around, the T cells learn that they should go attack these specific proteins. And then the T cells wander off, go in the bloodstream, and whenever they see a cell with that same protein, they try to kill it. That's how you get rid of some viruses. That's how you get rid of some bacteria. The normal system doesn't do very well with cancer. So he said, well, what do we inject in dendritic cells? If you put a tumor and you measure the size of the tumor, and you look at time, and you put the tumor in the animal, the tumor grows. Now, if at this time point, when the tumor is this big, you go ahead and give some chemo, well, you slow the growth down a little bit, but it keeps on growing. You put the dendritic cells in here, you slow it down a little bit, but it keeps on growing. But what if you give the chemo first, damage the tumor, so that now a lot of the proteins, a lot of the possible targets are now exposed. They're not protected by the tumor, by living tumor. They're now dead tumor cells just bathed with proteins. And then you put the dendritic cells right into the tumor. The tumor disappears and goes away. In fact, it goes away, and if I had another board, I'd be going out like this for the mouse's lifetime. The mouse's lifetime? The mouse's lifetime. My wife's an English major, so she says, just don't use it if you don't know it. So for the lifetime of the mouse. If you look at it a different way, and you look at the survival. Okay, so survival of the mouse. Well, of course, if you don't do anything, you get this kind of survival, right? Where this is time, this is percent surviving, so 100%, 10%. Now, if you just inject the tumor here, the tumor grows, and then it spreads to lung, liver, and the mouse dies. It's sad, but the mouse dies. If you inject the dendritic cells, maybe a little bit longer. If you inject chemotherapy, maybe a little bit longer. If you inject both, 90% surviving. Now, let's take this mouse here, who's out 8 weeks or so, 10 weeks, 12 weeks. Let's take this mouse who's happily living, his tumor's no longer there, and we'll try to inject another tumor. We'll put a needle right in here, and put tumor cells in there. It doesn't grow. That mouse is immunized against the tumor. It's incapable of growing. Furthermore, if you go ahead and look at these mice, they have lung and liver metastasis just like people get. If you look at these mice, not only is the tumor gone, but there are no lung or liver metastasis. So it's prevented a tumor spread, it's killed the tumor throughout. Now that's a nice kind of story, but he did some other interesting things. He went ahead and looked at a mouse with a tumor here and a tumor here, and he injected chemotherapy here and gave the dendritic cells here, and this tumor disappeared too. So it's not only affecting where it is and preventing spread, but it's attacking another grown tumor. That's pretty powerful. So we have a study that we just got FDA approval to do in November. Now we're working on other regulatory agencies, and we hope to start next month, realistically 2 months, in which we're going to be taking patients whose livers, this is a liver, who have a metastasis in their liver with colon cancer. And we can do a technique where we go in to the liver through the skin under CT guidance and heat that tumor. We're going to heat that tumor because we know we can kill a fair portion of that tumor by radiofrequency ablation, a way of killing the tumor cells. While we're in there, the same time we're in there, once it cools off, we're going to inject dendritic cells from that same patient. And what we're hoping to see is that those dendritic cells will then take up a lot of the tumor antigen right where the tumor is, and then spread to local lymph nodes and other areas where they can interact with normal T cells and educate T cells to not only go back and kill tumor cells here, but over here or in the lung or elsewhere. So that's a new vaccine approach that we're just about to start. It'll be the first intratumoral vaccine that has been tried. To give you another idea of how expensive research is, we started designing this 2 years ago. It took 2 years to get the money, to get the FDA approval, to get the machine that we wanted, to get the dendritic cells, to get all the regulatory agencies in line. It took, it'll probably cost us, me right now, and a colleague, Ed Engelman, who's in the blood bank, who's an expert on dendritic cells, along with Wenru Song, who's the fellow in Ron Levy's lab. It'll probably cost us in the vicinity of $25,000 per patient just to treat. We have no idea whether it's going to work. But we have enough money now to treat about 10 patients, and we're hoping to see some evidence of response that we could then get a grant to do a larger population. So these are expensive trials. They take a long time. They're not guaranteed to succeed. Lots of trials have not succeeded. But it's that kind of enthusiasm I want to relay to you, that we always have the optimistic idea that something around the corner is going to become available. We want to be part of that excitement. We want to offer that to our patients to the extent we can. And that's why I hope you came to Stanford to listen about this. If you have any questions, I'd be happy to stick around. And if you need to go, I understand. And thank you very much. So the advantage of the MRI for colonoscopy would be no radiation, number one. And there are some dyes that we think that we can tag stool with, which means just swallow a dye that will tag the stool, and then electronically, through the wonders of the digital world, you can then subtract anything with that dye, and then all of a sudden you have air. Right now, or what looks like air to the computer. Right now, what you have to do is drink a whole bunch of really bad stuff, spend the whole night in the bathroom, miserable, and then go in, not only then go in, but then go in and get pumped full of air, which is, by most reports, just as uncomfortable as the actual colonoscopy. So it's not that it's a breeze to get the virtual colonoscopy, but it's another way of doing it. And we're hoping to refine that further. I guess it depends on what the colectomy was done for. If the colectomy was done for colon cancer, and the colon cancer is not at an advanced stage, meaning it's stage 1, 2, or 3, and it wasn't a total colectomy, it was just a partial colectomy, then I usually recommend a colonoscopy a year out from that surgery or treatment, and then every year as long as there are polyps found. Actually, I'm a little bit more conservative. I usually go 3 years in a row now, and then if 3 years in a row there's no polyps, then I go every 3 or 4 years. Most people, I think, are more lax in allowing, you know, 1 to 2 years. There aren't really concrete recommendations for that. However, some people have total colectomies, particularly if they have 2 cancers. You might remove the entire colon, then you don't need a colonoscopy at all because there's nothing to look at, depending on the kind of surgery that was done. Some people with ulcerative colitis, we didn't talk about that. That's another group of patients who have a higher risk of developing colon cancer. Those patients need to have a look at their colon more frequently, and if they do develop a colon cancer, they probably should have a total colectomy, not just frequent colonoscopies. So the microsatellite instability in terms of clinical decision making is still a little bit nebulous. It's probably going to be of most value for people with stage 2 cancers. Now, stage 1 cancers, the surgeons cure them so frequently that no one would ever argue they should have chemotherapy. So stage 1 cancers, no chemotherapy. Stage 4 cancers, everyone needs chemotherapy. Stage 3 cancers, positive lymph nodes, we know statistically, very soundly, that people who get chemotherapy do better than people who don't get chemotherapy, you know, statistically. And so we always recommend chemotherapy for stage 3 cancers. Stage 2 is right on the fence, and it's a tremendous controversy. So one of the ways that MSI might be helpful is to help sort out those people with stage 2 cancers who might already have a more favorable prognosis and maybe don't need chemotherapy. In fact, the national trial that we will be participating in for all stage 2 patients will be to first do 2 molecular markers, not only the MSI, but another assessment of 18Q. And if both markers are favorable, then those patients won't get any treatment. Why? Because the statistics in looking back at patients with stage 2 disease who had those favorable markers, they had a 90% chance of cure, just like stage 1. But if you had either one that was unfavorable, then they get randomized to 2 different treatments. Let me tell you that I'm on the data safety monitoring board for our bone marrow transplant group, and because of the regulatory issues right now in terms of monitoring, and because they don't want to send me to Germany twice a year to go look at their data, it's very hard to do multi-institutional trials from a place like Stanford. Now, there are multi-institutional trials in large groups, and we belong to large groups, but the ones that I'm talking about are kind of homegrown. Frankly, I kind of like it that way. I mean, I like having full control over our patients so that if there's a toxicity, I saw that toxicity, I know how bad it was, I can document it, I can warn the next patient. If I saw a benefit, I know the degree of benefit. So we do, at Stanford, we kind of specialize in early feasibility trials, if you will, new drug trials, new ways of treatment. And then if they prove interesting or successful, then we bring them to the large groups and they go ahead and adopt them. Many of our lymphoma trials are now international trials that was started here at Stanford. A few of our, not our colon cancer trials, but a few of our ovarian cancer trials and other trials have gone on to a worldwide stage. Really, we are doing it on a small volume, trying to learn as much as we can. So our current strategy is to do it in conjunction with a colonoscopy, which you have to go through both, so that we can learn how best to do the virtual colonoscopy. Once we learn how best to do the virtual colonoscopy, then just like our trials, our radiologists will export that to other groups so that they can do multi-institutional trials. Then I bet you anything that ours will then work on the next generation of virtual colonoscopy, trying to perfect it even more. So I don't know that Stanford will necessarily choose from the academic side to become a mass screening center, because you can get that anywhere once the test has been developed. We try to be the innovators in small scale.